This program is brought to you by Emory University.
Well, good morning, everybody. Welcome to Friday Morning Fellows Conference. Our speaker this morning, as you can see, is Dr. Devinder Dhindsa. Devinder is a fourth-year fellow in our program. As many of you, I'm sure, know, he did his undergraduate at Emory University, then George Washington for medical school, back to Emory for residency and now fellowship. He's in our clinical investigator track, did research with Dr. Sperling and others during his research time. He's going to present. He was the CCU fellow at Emory University Hospital last month, where they, I think, had a little run of post-MI VSDs. I think he's going to talk a little bit about that today. So take it away, Devinder.
All right. Thanks, Dr. Williams. So I'll be presenting the case of a patient who was admitted to our CICU last month. Unfortunately developed an acquired VSD post-myocardial infarction. I have no relevant disclosures. So this patient was a 73-year-old male with a history of hypertension, hyperlipidemia, hypothyroidism, and prior TIA. Presented to the outside hospital ER on September 3rd with complaints of intermittent chest discomfort over the past 5 days. Since 10 a.m. that morning, he had described constant substernal chest pressure, quote, feeling like I have to burp but can't, headache, and weakness. His EKG in the ER on the 3rd was markedly abnormal. You see Q waves in the anterior precordial leads. You see ST elevations in the same distribution. You see a loss of anterior forces, and you also see inferior Q waves. So his troponin I measured at the outside hospital was 5 nanograms per milliliter. Cardiology was consulted in the ED. Per their consult note, the ECG was felt to have represented a completed LAD infarction. However, the patient had continued ongoing chest pain that had become increasingly severe despite nitrates given in the ER. And so he was referred for urgent cardiac catheterization for evaluation of his anatomy and potential revascularization. So here's his cath from the 3rd. The RAO cranial view, you see that there is significant disease in the circumflex. More notably, there's very tight stenosis in the proximal LAD. But the most striking thing on this angiogram is the 100% mid-LAD occlusion. They were able to get a wire across the occlusion, and they did attempt PCI with serial balloon dilations. However, after several balloon dilations, they weren't able to restore flow to the distal parts of the LAD and apex. So this is their LV gram done in the RA view. And again, you see apical akinesis. This was a transthoracic echo done roughly around the same time. You see an apical 4-chamber view. You see that the LV systolic function is severely reduced with apical akinesis and what appears to be a small LV thrombus at the apex that was not called at the outside hospital. RV function appears grossly preserved, and the RV size is grossly normal. So here's a 3-chamber view showing similar findings of apical akinesis. The base seems to be contracting well. Color Doppler was placed across the interventricular septum, and at that time there was no obvious shunt noted across the septum. So on September 5th, so hospital day 3 for him, he had an increase in oxygen requirements with a chest X-ray showing worsening pulmonary edema, required intubation for hypoxia. Also developed significant hypotension, requiring initiation of dobutamine, dopamine, epi, levophed, and vasopressin. And they were able to achieve some semblance of hemodynamic stability on significant vasopressor and inotrope support. However, on the 7th, despite this level of support, he remained hypotensive in the 70s over 40s. Decision was made to upgrade to mechanical circulatory support, and so CT surgery placed a 5/5 impella via the right axillary artery. They noted low flows on the axillary impella despite setting it at P9, so there was concern for concomitant RV failure. And so an RP impella was placed as well via the right femoral vein. Late that evening on the 7th, a limited bedside echo was done, and it shows the following. Subcostal view, you see that there is, the RV does appear dilated. The systolic function appears worse than prior. LV shows severely reduced systolic function. You see the RP impella and the 5/5 impella. This appears to be directed more so towards that posterolateral wall. But the most striking feature on this echo is that echo-free space in the interventricular septum. So at this point, we were called for emergent transfer. Unfortunately, his flight by helicopter was delayed on the 8th because of storms. He reached our hospital via ambulance early morning on the 9th. And CT surgery and structural cardiology were consulted regarding urgent repair. So here is an apical 4-chamber 2D TTE done at our hospital. And again, the most striking feature on this, well, there's several striking features, but one being that echo-free space in the interventricular septum. There also appears to be a mobile mass at the apex. Color Doppler across the interventricular septum shows left to right shunt through that defect. Then we did obtain contrast images. Again, you see that defect well. You also see this mass that I was speaking of in the apex. Unclear whether that is LV thrombus or part of the septum that after rupture had prolapsed into the LV. So we had a right heart cath done on the 9th and a Swan-Ganz catheter placement. This was on dobutamine 2.5 micrograms per kilogram per minute, an RP impella set at P8, and an impella 5/5 also set at P8. The CVP was 16. The RV pressures were 52/14. The PA pressures were 60/28 with a mean of 38. The wedge was 26. Central venous sat was 68.3. Mixed venous was 84%, and his aortic sat was 96.3. This calculated out to a systemic cardiac output, an index of 6.4 and 2.8. His systemic vascular resistance was 700 dynes, and his shunt fraction calculated by QP/QS was 2.3. So through heroic effort by our nursing staff, respiratory therapy, our CICU attending, and the EP consult fellow, we were able to get this patient over to the tower for a CT scan for preoperative planning, which revealed, as seen here, a large VSD, 14.2 millimeters by 24.7 millimeters in the mid to apical infraseptum. So unfortunately, the patient continued to deteriorate clinically. He developed a mixed distributive and cardiogenic shock. The distributive shock was thought likely due to sepsis secondary to a pneumonia. ID was consulted. The patient was placed on broad spectrum antibiotics and antifungals. His course was further complicated by renal and hepatic failure. And at this point, the team and our consultants recognized that a decision should be made urgently for intervention or not. So here's a note from the CT surgery attending. A surgical repair would entail on-pump surgical patching / closure of the septal defect, cabbage times 1 to 2, and he would definitely require temporary mechanical circulatory support with ECMO. In my opinion, he is at very high risk of complications from surgery, and extremely high risk of complications with ECMO support, which approaches futility. I have discussed this also with my partner, and he concurred. Based on that, the patient is not a candidate for surgical repair or ECMO support at this point. So his partner also left a note. Leadership discussed the use of ECMO in this particular patient in the context of the current available resources at Emory University Hospital at this time, given the current surge in COVID cases. Due to the recent COVID surge and limited resources of beds, ECMO machines, and nursing staffing at Emory University Hospital, we are currently reserving the use of ECMO for younger patients and are unable to offer this resource to this patient at this time. So the CICU attending also left a note. Patient continued to deteriorate throughout the evening, and this AM with progressive cardiogenic shock complicated by vasoplegia and renal failure, requiring increased vasopressor support. He was discussed with our CT surgery on call. We felt he should be considered for surgery for VSD closure, as it was clear he would not survive the weekend. Given the degree of shock, he would require ECMO post-surgery. The overall mortality was high. The patient data was reviewed by Cardiology Chief of Service and CT Surgery Chief. It was felt by surgical leadership that ECMO utilization should not be offered to this patient because of limited resource during the COVID-19 pandemic. Given this limitation, high-risk surgical VSD closure is not a reasonable approach. Additionally, structural intervention would also require ECMO. As such, there is no reasonable option forward. I discussed this with the family, and decision was made for comfort care. So on the 12th, the patient was extubated, vasopressors were stopped, and he expired shortly thereafter. So post-MI ventricular septal rupture, it is a catastrophic complication of acute myocardial infarction. It was first described at autopsy by Dr. Latham in 1847, but an association with an antemortem diagnosis wasn't made until nearly 100 years later. The first surgical repair of a VSD following MI was reported by Dr. Cooley in 1957, and notably this was 9 weeks after the initial detection of the ventricular septal rupture. So the incidence of ventricular septal rupture was 1 to 3% in the pre-reperfusion era. In more modern trials and registries, the incidence has decreased to 0.2 to 0.3%, and this is thought due to early reperfusion strategies which salvage ischemic myocardium and limit infarct expansion. So as far as the risk factors for post-infarct ventricular septal rupture, older age, greater than 60 years, female gender, no history of prior MI, hypertension, and one of the most important ones is delay in or lack of reperfusion. As far as the presentation of these patients, they present with post-MI cardiogenic shock, pulmonary edema from increased right-sided pressures due to left to right shunting, clinical evidence of biventricular failure, and a new, loud, harsh holosystolic peristernal murmur that's associated with a thrill in about 50% of patients. And there's a bimodal peak, the first peak being within 24 hours, and the second peak being 3 to 5 days or potentially later. And we'll talk about the pathology behind that bimodal peak in 2 slides. So as far as the pathogenesis, a necessary component of ventricular septal rupture is a transmural infarction. At the microscopic level, this is followed by hyaline degeneration and fragmentation of the extracellular matrix, subsequent enzymatic digestion. At a more macroscopic level, fissure formation occurs, and this is followed by frank septal rupture. So there are 3 types of ventricular septal ruptures. These autopsy images here are free wall ruptures, but the classification is the same for both. So it's the Becker and Van Manchem classifications. Becker type 1 ruptures are slit-like tears through normal thickness myocardium They occur abruptly within 24 hours of an MI, and they're typically related to intramural hematomas dissecting through tissue planes. And they usually occur in the setting of an inferior MI, as is shown with this Becker type 1 rupture in the free wall. Type 2 ruptures typically result subacutely from erosion of the infarcted myocardium and are associated with neutrophilic infiltration and coagulation necrosis. And type 3 ruptures result from perforation of thinned aneurysmal myocardium in the late phase post-MI, and they occur more frequently in the absence of reperfusion therapy. Ventricular septal ruptures in these settings occur subacutely or late after the index infarction. As a result, there's a bimodal distribution of time to rupture, with ventricular septal ruptures occurring within hours, as in type 1 ruptures, or within 3 to 5 days, or even later for the type 2 and type 3 ventricular septal ruptures. So ventricular septal ruptures occur more frequently in patients having their first ischemic episode due to an absence of collateral circulation that increases the risk for transmural infarction. The LAD and a dominant RCA are the most commonly infarct-related arteries leading to septal rupture. Anterior infarctions typically lead to apical ventricular septal ruptures, and usually these are technically easier to repair as the rupture occurs at the same level on both sides of the septum, usually. Inferior MIs tend to cause much more complex ruptures. They take serpiginous routes and go through a necrotic basal inferior septum. So as far as the anatomy, transmural tissue necrosis through the interventricular septum causes a dynamic perforation, and it's usually at the interface of necrotic and non-necrotic myocardium. The architecture can be complex. You can have serpiginous tunnels traversing the interventricular septum, particularly in ruptures associated with inferior MIs. And then to further complicate repair, multiple orifices can also occur. As far as the coronary anatomy associated with ventricular septal defects, a dominant RCA at the level of the base will feed the inferior portion of the septum. The anterior septum is fed by the LAD. And as you move more apically, the LAD shares a greater burden of supplying the interventricular septum. So the diagnosis is usually initially made by transthoracic echo, although 2D echo without color may only be suggestive of thinned or focally absent myocardium, and often is not as obvious as was seen with our patient. Color Doppler can definitively demonstrate the location and extent of the shunt. As far as the pathophysiology, you have an abrupt development of a left to right interventricular shunt. You have a sudden decrease in systemic cardiac output. You have a sudden increase in RV overload, leading to pulmonary congestion. And depending on the size of the index infarction, the degree of shunting, and RV dysfunction, patients may manifest with hemodynamic stability or frank cardiogenic shock. So as far as quantitation of the left to right shunt, this is determined by the shunt fraction, or the QP over QS, the flow through the pulmonary circulation divided by the flow through the systemic circulation. It's determined by the relative vascular resistance in the systemic and pulmonary beds. A Swan-Ganz catheter placement is a class 1 indication for mechanical ruptures, for mechanical complications of STEMI, and this is helpful in revealing a step-up oxygenation saturation, and can also be helpful in calculating the QP over QS. So as far as treatment for ventricular septal ruptures, according to the STEMI guidelines, surgical correction, irrespective of hemodynamic stability, is a class 1 recommendation. CABG for underlying disease at the time of repair improves long-term outcomes and is also a class 1 recommendation. The cornerstone of management while awaiting surgical repair is LV afterload reduction to reduce the degree of left to right shunting. Diuretics and IV nitrates can be helpful in this regard, although these patients tend to be critically ill, and so our use of nitrates in hypotensive patients is limited. Inotropes are often required. Cautious use or even avoidance of vasopressors, given the increase in LV afterload. And mechanical circulatory support has really become an important tool in our toolbox for the stabilization of these patients as they await definitive repair. So published series suggest a graded decline in mortality with a greater delay in ventricular septal rupture repair. This finding's likely both a true association due to increased stability of the peri-infarct myocardium, which renders a repair more successful. Also likely there is some survivor bias associated with this finding. So in the Society for Thoracic Surgeons National Database, they found 30-day mortality of ventricular septal rupture repair of surgical mortality of 43%, which is the highest of any cardiac surgery. There is a sharp decrease in mortality with delay in repair. According to that registry, there's about a 54% mortality if you operate within the first 7 days. This drops off to about an 18.4% surgical mortality if they're able to survive to day 7. Obviously, selection and survivorship bias confound these results. Importantly, cardiogenic shock is a marker of especially poor prognosis with these patients. Surgical and transcatheter repair in patients with cardiogenic shock approach 90%, and in some trials and registries, greater than that, approaching 100%. So here is a treatment algorithm that's on the ACC website. This differs from the current STEMI guidelines in that patients are divided between those with stable hemodynamics and those in cardiogenic shock, given the high operative mortality of those in cardiogenic shock. For those patients with stable hemodynamics who are surgical candidates, the recommendation is made for either early surgical repair or delayed surgical repair if possible. And we'll talk about the reasons behind a delay in surgical repair. If they are not surgical candidates, then either transcatheter septal closure or conservative management for these patients is recommended. For those in cardiogenic shock, then again, this algorithm is slightly more in line with contemporary practice than the guidelines. So they suggest a mechanical circulatory support bridge as a bridge to a definitive repair or palliation. So acute therapeutic options are often technically difficult as the tear in the septum is complex and the infarcted myocardium is edematous and necrotic and continues to evolve over several weeks after the infarction. Concomitant LV and RV dysfunction also limit the safety of surgical repair and increase operative mortality. Use of early mechanical circulatory support in patients with hemodynamic instability may serve to bridge patients to a decision of delayed repair, transplant, or palliative options. So as far as the surgical repair and the timing of it in patients, in stable patients with preserved end organ function and favorable anatomy, early corrective surgery should be considered as these patients can deteriorate hemodynamically suddenly and unexpectedly, as our patient demonstrated on several occasions. In patients in whom the anatomy is more complex and there's concern about the tissue architecture and fragility and the ability to perform a definitive repair, a delay in surgery is reasonable in those who are hemodynamically stable. The rationale behind a delay in surgical repair is that following infarction, tissue breakdown peaks by day 7. You start to have new collagen deposition by days 2 to 4. And by 28 days, the necrotic myocardium is almost entirely replaced by collagenous scar. Therefore, a delay may allow for a more successful repair by allowing this necrotic myocardium to organize, strengthen, and become well differentiated from the surrounding healthy tissue. If you're going to be delaying a repair in these patients, they should be monitored closely in the ICU, as these patients have a tendency to deteriorate suddenly. So like I said, mechanical circulatory support has become an important tool in our toolbox. The three main modalities we have at our hospital: balloon pump, VA ECMO, Impella, and a combination of two of these modalities are frequently used. And I'll be talking about the use of these patients with this particular physiology. So as far as intra-aortic balloon pump support represents the first line mechanical circulatory support strategy in patients with cardiogenic shock post-acute MI. And those with mechanical complications. That's a class 2A recommendation in the current STEMI guidelines. It has several advantages in that it provides afterload reduction, decreases LV wall stress, increases contractility in that way, and does reduce left to right shunting through all of these mechanisms, namely the afterload reduction. It is the safest from a vascular complication standpoint of our mechanical circulatory support choices, and it is the most cost efficient. However, in these critically ill patients, we are limited in the support that's provided by intra-aortic balloon pumps, and for preserved end organ perfusion, we typically have to move to a larger device. This is just a cartoon of an intra-aortic balloon pump. So as far as VA ECMO in these patients with this physiology, it does provide improved hemodynamic support as compared to other mechanical circulatory support options to maintain end organ perfusion. It does also provide oxygenation in the event that the shunt reverses from a left to right shunt to a right to left shunt. However, there are several cons in that in peripheral VA ECMO, you actually increase LV afterload, you increase LV wall stress, thus increasing left to right shunting, and you increase subsequently the pressures on the right side, pressures and volume on the right side. Also, due to increased afterload, you can have aortic valve closure. That is a risk that leaves a risk for aortic root thrombosis. So the left to right shunting and PA overflow associated with VA ECMO can be overcome with a PA-based draining cannula. And then concomitant use of the balloon pump or Impella, the ECPella, may be used to reduce left to right shunt, unload the LV, and just based inherently on how these devices are positioned, prevents AV closure. So this is a rendering of the 5.5 Impella from the Abiomed website. The Impella does provide hemodynamic stabilization. It is very effective, particularly the 5.5, in LV unloading. You have shunt reduction, which provides an important relief of RV overload. Caution should be taken with high flows, as you do have a risk of shunt inversion and causing deoxygenated blood to go from right to the systemic circulation. There's also a risk of hemolysis at higher flows, although it's much less of a risk with the 5.5 Impella as opposed to the CP Impella. Care should also be taken to make sure that the device is correctly positioned so it's not sucking RV blood and creating a right to left shunt in that way. However, if a patient is crashing, the idea of additional support through mechanical circulatory support is moot, and you need to move directly to either surgical or percutaneous intervention. So as far as percutaneous intervention, transcatheter septal closure is typically reserved for those patients who are not candidates for surgery. Dedicated endovascular devices are best suited for particular anatomies, including patients with thin septums, small circular defects, and these tend to work better in those during the chronic phase of post-infarct VSD. This is because these commercially available devices have an outward force at the spoke that expands through an already necrotic myocardium. It can also cause, with high permeability defects, you can fail to occlude and you can have residual shunt. Also, the ventricular septal rupture tends to evolve as a necrotic myocardium is replaced by collagenous scar. And so the characteristics and size of the defect tend to change. And so these patients may have residual shunt following, necessitating either a redo operation or are susceptible to complications such as device migration. So this is a technique that was developed by the structural team here at Emory, as well as a CT surgery team. It's called bassinet. Stands for bridge across the septum using sutures in a non-endoluminal trajectory. So this is a hybrid surgical procedure which is performed in the hybrid OR under general anesthesia. The RV free wall is accessed via a subxiphoid approach. Using echo and fluoroscopy guidance, they traverse the center of mass of the defective tissue in a non-endoluminal trajectory rather than navigating through the defect itself, as the defect can be serpiginous and take a complex route. They go through the center of the infarcted myocardium. An introducer sheath is advanced, and then you place an occluder device on the LV side and the RV side. These devices are connected by nylon sutures that are sutured through the devices before implantation, and then they're tensioned snug across the septal rupture and tied using a core knot through the sheath. So palliative care is also reasonable in these patients, given the grim overall prognosis. Patients with severe end organ failure, despite aggressive support, can be transitioned to comfort care depending on the family wishes. So this case also highlighted the issue of resource allocation during the COVID-19 pandemic. As you recall, last month was the height of hospitalizations secondary to the Delta strain of the coronavirus. And so our ICUs were at capacity and our ECMOs were also very scarce. Two of the more rare resources that we encounter are ICU beds and ECMO. So there have been some considerations that have been proposed as components of allocation systems, such as likelihood of surviving the admission, which is most frequently assessed by metrics like a SOPA score. Likelihood of near-term death, assuming survival to discharge, it's most frequently assessed by presence of severe comorbidities likely to result in death in the next 1 to 5 years. Age, again, is a component of resource allocation. And then essential worker status, because of the importance of maintaining critical infrastructures. So this was a paper that came out early on in the pandemic. It was first published online in March 2020, so a few weeks after the onset of the pandemic, and then published subsequently in print in May of 2020. And again, this provides several recommendations for fair allocation of scarce medical resources in the time of COVID-19. Recommendation 1, the value of maximizing benefits is most important. For example, reserving ECMO for patients who are more likely to survive to discharge and have fewer comorbidities. So a responsible stewardship of rare resources. Recommendation 2, critical COVID-19 interventions should go to those who keep critical infrastructure operating. Recommendation 3, for those with similar prognoses, equality should be invoked through random allocation of scarce resources. Recommendation 4, prioritization guidelines should differ by intervention. An example of this is reserving ECMO for those younger patients with fewer comorbidities and the vaccine in times that it was scarce, reserving those for higher risk patients who are more likely to develop severe COVID-19 infection. Recommendation 5, again, this was early on in the pandemic before we had a widely available vaccine, but people who participate in research for the vaccine should be given priority for medical resources. And recommendation 6, there should be no difference in allocating scarce resources between patients with COVID-19 and those with other medical conditions. So this is proposed guidelines for allocation of ECMO during the COVID-19 pandemic. This was published in the Annals of the American Thoracic Society. And here's some indications for VV ECMO, but the contraindications they list here, more stringent than those in our typical practice. Active malignancy being an obvious one. Age greater than 65, high-grade shock, multi-organ failure, inability to tolerate anticoagulation through the ECMO circuit, invasive mechanical ventilation for longer than 7 days, irreversible neurologic injury, and expected life expectancy less than 6 months. Some relative contraindications include thrombocytopenia, neutropenia, morbid obesity, long-term oxygen dependence, and inability to perform ADLs at baseline. Now, obviously, these are areas of controversy and merit further discussion regarding allocation of resources. There's been a desire to avoid allocating resources along simple first come, first serve lines. So attention to the importance of non-discrimination to make sure that allocation systems do not deepen inequities. This gets tricky because obviously you don't want to discriminate against older individuals. However, prioritizing younger individuals would clearly improve outcomes. Also, baseline comorbidities tend to be overrepresented in minorities and low socioeconomic status patients. Also, there's an area of controversy is willingness or acceptance of the idea of withdrawing support for people who are, quote, lower priority. So decannulating an older individual with multiple comorbidities who's not doing well on ECMO in order to place a younger patient on ECMO is a difficult ethical decision. And then also, recent attention has been paid to issues such as vaccination status, and some have argued that unvaccinated individuals should be deprioritized versus those who are vaccinated and individuals with non-COVID illness. So again, that is controversial, but an area of discussion. So I want to thank Dr. Sahu and Dr. Dickert for reviewing the slides, providing content, and everything else that they've done for this presentation. And with that, I'll take any questions or comments.
Thank you, Devinder. Nice work, good review of a tough case, obviously. I guess my question is, it's probably scarce data out there. It does seem sort of that we have seen an uptick just being in the echo lab of post-MIVSDs in the COVID era, probably from people reluctant to seek medical care. I assume you didn't see anything in your research regarding that.
So yeah, a lot of the evidence that I had seen is more anecdotal. I know our experience over the past 18 months and talking to the fellows and attendings, we have seen an uptick in the numbers of VSDs as opposed to what we had seen in years prior. Most of what I had seen were anecdotes in case reports in which patients are quoted as saying they were reluctant to come in because of the COVID-19 pandemic, but I didn't see any hard data about that, specifically with ventricular septal ruptures. There is data that the number of cath lab activations for STEMI, especially early on in the pandemic, decreased by 30+%. And so you would imagine that a lot of these patients who would have otherwise come in would suffer mechanical complications of myocardial infarction and potentially die at home or present with some of these bad complications, but I didn't see any hard and fast data about ventricular septal ruptures in particular.
This is Neil. I with regard to this particular issue, it's pretty striking, at least from the perspective of working in the CCU. I guess I've been here as an attending close 9.5 years, something like that. I think in the first 6 or 7 years, I saw maybe 2 or 3 VSDs, and certainly have been either directly or peripherally involved in somewhere like 5 or 6 in the last year or so. I think there's probably, these data are gettable. There's probably a role for some sort of short report of our experience, because the difference is truly dramatic. I think it's very difficult to sort out exactly what it is. I've looked back through to see, who's vaccinated, who's not, is there COVID exposures, is not, to see whether there's any sort of more direct relationship with regard to this. Doesn't seem to be, there's any clear pattern there. So you have to presume that there's sort of some form of delays in presentation, or potentially EMS availability. I mean, who knows exactly what the source is. In a sense, it doesn't matter. I think it's actually a really interesting documentation of a peripheral kind of bystander effect of COVID that I think does nicely complement the literature that we've seen with regard to worsened outcomes in stroke and delayed presentations for other kinds of illness. So I think there's potentially a role for this. I haven't seen it reported, and I think our numbers are enough to be at least interesting as a very short piece. So I encourage you and others to pursue that. One thing with regard to the resource allocation pieces, Devinder did a nice job of sort of talking through some of the considerations that have been there. At different points in the pandemic, there have been more or less active discussions about initiating kind of triage protocols, and there are plans in place that our institution has developed in terms of adopting a version of some of the allocation systems that have been there. But Devinder's right that in general, the prioritization for the 2 primary factors to be taken into consideration for at least the system that Emory has kind of adopted are really sort of likelihood of dying in the hospital. And obviously in this case, this patient's likelihood of in-hospital mortality was, I don't know what you'd say, Devinder, but probably somewhere in the order of 80 to 90%. If they went to surgery. And then the notion of pre-existing or sort of likelihood of how they're going to do after the discharge. And there's a sort of 2-tier point system. One is with someone who's likely to die within a year, even if they get out, kind of independent of their current admission. The other people have comorbidities that are likely to result in death within 5 years. You guys have seen how you get asked those questions sometimes on admission for patients, and that's how that's in order to help to feed that scoring system. I think with regard to the COVID piece and the resource constraints at the time, my sense is most COVID mortalities of sort of, I guess, appropriately selected patients, those folks have, I think it's been a moving target, and I don't know what the Emory experience has been, but it looks like there's sort of 40 to 50% survival of if you get put on ECMO with COVID. So it is probably different from something like what's going on here. I think one of the questions when these things get invoked, though, is, what was the current state in terms of ECMO utilization at that time, right? And so one of the operational challenges with all of this is the notion of creating reserve systems and things like that in terms of trying to anticipate need versus just what do you do with one ECMO machine in terms of who's coming in that day. That gets operationally challenging.
Hey, Devinder.
Yes, sir.
That was a great presentation. So you mentioned Dr. Cooley. So Dr. Cooley used to tout all over the country and world that he got almost all of these patients through and surgery. And Dr. Hurst used to say, or talk about a patient he had one time that was down in the island somewhere that he somehow diagnosed VSD over the phone and got to Dr. Cooley, and he fixed him and he survived. So the bottom line of that later became obvious that if you can wait long enough and get to Houston, then you can survive the surgery, because you were talking about in the algorithm, one of the options is to delay and let it heal up. I mean, we've even had people that have come into this hospital with a VSD that happened 6 or 8 weeks before, and it was kind of incidentally found. And those people do survive.
Right.
So also pre-intervention, it became obvious to everybody that surgery for these people was very difficult. And many times when the surgeon finished the operation, you look down at the heart, and I've been down in the operating room and looked at these hearts, and it was called a Teflon heart because there was so much patching and so many pledgets in there, so much Teflon patches and all that kind of stuff. Just really didn't work well. So this percutaneous approach is exciting, but it's beginning to separate out a little bit. For example, the inferior infarctions that have the basal septal posterior defects that are associated with those aneurysms that you showed so nicely. Those are very difficult. If it's a mid-LAD lesion and the distal LV is involved, the distal septum is involved, then you have more options. So we've come a long way, but it's still a high-risk thing. I always like also to ask about, like, how do you diagnose ruptured septum? And suppose you're standing in the ICU, and suddenly the nurse comes out of the room and she says, "I hear a murmur." And then things go into your mind, say, well, is she really hearing a murmur? Or is she hearing a rub? Or is she hearing the ventilator? Or what? So then you get your stethoscope and you go in there and you try to separate it out, and you hear the murmur, the left sternal border, just like you described. Well, you say, well, what is this? Momentarily, when you rupture the heart, you might hear a murmur, although I've never heard it. But you know there must be a murmur momentarily. I don't know anybody that's heard it. But in ruptured septum, if you hear the murmur, it's one time when a loud murmur is a good sign.
Right.
And that loud murmur means you have a high gradient. And on echo, you know how to calculate the right ventricular systolic pressure once you know the blood pressure and the jet velocity across there.
Yes, sir.
So the loud murmur is a good sign. When the murmur starts changing, then that's not a good sign.
Right.
So then you can diagnose it with echo, of course. Then you get into all the options from the standpoint of where it is. I know Dr. Babilaris likes those CT scans, and I also heard you describe the manpower it takes to get one of those.
Yeah.
It takes a
It's a 7-person team
too. So that's a challenging thing, and that certainly is not available everywhere. And it creates absolutely beautiful images.
Yeah.
But if you look at those images side by side with echo, they're very similar.
Yes, sir. Yeah.
So I know that's kind of part of what we've been doing recently, but that's a little challenge.
Yes, sir.
Oh, thanks for your presentation.
Thank you.
Good job. All right.
Thank you.
Devinder, this is
go
Neil
ahead.
again.
Yes, sir.
I was just going to add one more brief
Yeah.
piece that is interesting. Hopefully, we're going to go back to a point where we don't see these as much. It sure seems like there's been a rash, but the use of the 5.5 Impella as a strategy for helping to manage this, I do think it's just worth saying explicitly that has changed the way I think we've thought about this a little bit, at least in terms of, there's been a few of these patients where we've been able to get them out several weeks because we have a device that is a bit more manageable, workable, and powerful. And we've had some success with that in terms of being able to delay interventions long enough to be able to get through that sort of critical period. So it is probably true that the management of a post-MI VSD is in some sense different right now than it was even a year and a half, 2 years ago. And our whole, in addition to the percutaneous closure options, I really think our ability to just kind of support people to a more durable therapy certainly has improved. It's not perfect, but it's improved.
Yeah,
Right.
that's what I was going to bring up earlier, that obviously we think that COVID may be playing a role in this uptick, but maybe there is that with improved percutaneous options as a referral center, more of these people are surviving to get to us. And maybe that's why that may be contributing to this uptick that we've seen because of the better percutaneous support options that can be put in place at outside centers to keep them alive.
Yeah.
Okay.
I was going to say this, the argument can be made that as soon as you diagnose a ventricular septal rupture, then you should move potentially quickly to putting in a 5.5 impeller, because it does do such a good job of unloading the LV and reducing that shunt. So that's been our practice for the one patient I've been involved with.
Thank you, Devinder. You're an expert. And thank you to everyone else for tuning in this morning, and we'll see everyone next Friday.
The preceding program is copyrighted by Emory University.